Before we get started, I do want to introduce Kelsey. Kelsey's like in the middle of the room. That's awesome. Kelsey is our newest faculty member. She started, did you start adjunct? How long ago? Well, tell them about you.
About 2 years ago.
2 years ago, you started adjunct?
And yeah, so recently took a full-time position with Western. So I'll be helping Hillary with Job 1. Since I'm kind of coming in midstream, I'm just gonna be kind of observing for probably the rest of the term. And yeah, I've recognized a few of you from clinical. Previously I've taught term 1 clinical, so
I wonder if you had any of them. Yeah. So you're gonna do term 1 clinical and then you do good skills, right?
basic
Basic
skills.
skills, first level.
Yep.
And then she's helping Job, so. Base, so. Another helper. So when Michelle's here, I'll introduce you to Michelle, so. But welcome and we're glad that she's here. It's good to have a partner. All right, so we discussed what last week? Thyroid, okay, we talked about the thyroid. Talked about diabetes. What else did we get to? The pancreas, yeah. What else did we talk about? Did we do another one? DI, SIADH? Okay, so what hormone are we talking about there? ADH, yep, antidiuretic hormone. Okay, so I have some activities that we'll do to kind of go back and review some of that content. But we're gonna start talking a little bit about the adrenal gland. We'll talk about Addison's and Cushing's to start with this morning, then we'll do some other activities. So the adrenal glands, right, sit on top of the kidneys. There's a next picture here, talks about the adrenal glands. They sit on top of the kidneys. Okay. So that cortex is what we're concerned about when we talk about this unit. And which hormones does the adrenal gland secrete? When we're talking about the cortex, we're talking about our disease processes. What hormones are we concerned about now? Yep. So glucocorticoids. Yep. Or steroids, and what else? And mineralocorticoids, which is what? Aldosterone, right? We talked about aldosterone before when we discussed in fluid electrolytes, right? Okay. It also talks about the androgens.
Oh, I thought it was.
Those are your sex hormones. We're not going to talk too much into those, but those also can be affected, right? When we talk about those hormones, okay? So we're talking about the cortex, the medulla. Then those hormones have to do with like norepinephrine and epinephrine, your catecholamines. And again, we're not going to go too much into that. We're going to focus more on your cortisol, and we're going to focus on the aldosterone. Okay. So tell me what glucocorticoids, okay, we're talking about cortisol. What do those do? What does that hormone help with? Okay, the stress response. Yep, definitely stress response. Increases when we're stressed. Okay, what else?
The blood glucose.
Okay, yep, it affects the blood glucose. The higher the cortisol, the higher the blood glucose. Yep, what else? We're talking about cortisol.
Replaces it.
What does it do? Yeah, what does it do? So we talked about stress response. What else? Emotional.
Suppresses the immune system.
Yep, higher amounts. Yep, it helps the cortisol, helps with the immune system. Okay, metabolism. Yep, carbohydrate, protein, fat metabolism. It also has a little bit to do with the fluid and electrolyte balance too. Okay, so your glucocorticoids, right? Those are your steroids. Right. What about your mineralocorticoids? So we're talking about aldosterone. What did we say that does? What does aldosterone do? Why do we need it? Yeah, holds on to water, right? Holds on to water, salt, and then what does it help excrete? Potassium, okay? You have to understand what the hormone does, right? That'll help you realize if it's low, if it's high, what signs and symptoms are negative. Okay, and then the sex steroids that we're not gonna really talk about, the androgens, the estrogens, right? The progesterones, the female and male hormones, okay? All right. This is just another kind of pathophysiology wise, but I want to talk a little bit about the controls and the actions of the adrenal glands. Okay, so remember the hypothalamus, right, talks to the anterior pituitary, which sends hormones, signals to the adrenal glands. Okay, so the hypothalamus makes CRH, which tells the anterior pituitary to release ACTH, which then the adrenal glands will start secreting those hormones. Okay, your steroids and your aldosterone. Okay, that's how it should work, right? And if there's too much hormone, what should the hypothalamus, the pituitary say to do?
Stop.
Can you just secrete or should it stop?
Stop.
Right? And then if we need more hormones,
Excrete.
right, the hypothalamus is going to excrete more, which is going to tell the pituitary, which is going to tell the adrenal glands. Okay. What do you know about exogenous corticosteroids? What does that mean? Outside, right? Exo kind of outside. Where would we be getting outside corticosteroids? Yeah, medications. Okay. Prednisone, right? What kind of medication is prednisone? It's a steroid, it's a glucocorticoid. Right? So our body is getting outside sources, right, of steroids. Is that going to tell the hypothalamus pituitary gland to say, oh, I don't need to produce anymore? Okay, what's going to happen to those adrenal glands then?
They're not gonna excrete.
They're not going to excrete because they don't have to, right? They already have an outside source. Okay, so what happens to the gland? It starts to atrophy and it doesn't produce corticosteroids. Okay. Who is on chronic long-term corticosteroids like prednisone? What is that? Addisons, okay? Yep, okay. What else? Who else is on outside sources of long-term steroids? Who have you given prednisone to? Respiratory patients, COPD patients. Who else? Anybody ever had a severe allergic reaction? Maybe had to be put on prednisone or some type of glucocorticoid? Okay. Chemotherapy patients. Okay, part of the protocol for chemotherapy. Okay. So if these patients are on chronic, long-term prednisone or glucocorticoids, when they stop it, what do we have to worry about? If they would just stop taking them for 2 years, all of a sudden they're like, no,
It's not gonna.
not gonna do it
produce-
anymore.
Not gonna produce enough.
Adrenal glands, are they gonna start producing right away? Right? So what do we have to do to that glucocorticoid dose?
Paper.
Yeah, to taper it off, right? So slowly lower the dose over a time period. So is it very important to teach your patients that they need to take that medication every day as prescribed? Yeah. Okay. Okay. All right, so we are going to talk about first about what happens when you have hypofunctioning adrenal glands. Okay. Then we'll talk about hyperfunctioning. Okay. So this may also be called adrenal insufficiency. You may have heard of it. Another term is Addison's disease, and that's a primary form of an autoimmune disorder. Okay, but it all has to do with the adrenal gland hypofunctioning. Okay, it might be again problems with secretion of the ACTH. It might be problems with the hypothalamus to the pituitary, right? The talking between them, or it might be a problem with the adrenal gland itself. Okay, there's a lot of different causes, right? When we talk about acute adrenal insufficiency Addisonian crisis, I'm going to come back to this slide, okay? Because we're going to use this slide to talk about what happens when we're in a crisis, okay? But I want to talk about what just happens when the adrenal glands have some hypofunction, okay? So Addison's disease, hypofunctioning adrenal gland. Okay, there's a lot of different causes, right? The primary cause has to do with the adrenal gland itself. For some reason, the adrenal gland is not producing enough, not responding, Okay, secondary then has to do with the pituitary or the hypothalamus, something going on there. Okay? So different causes. Your sudden cessation or stop taking glucocorticoids is considered a secondary cause. Okay, pretty big cause of that. All right, so let's think about, when you think about a patient who has Addison's disease, let's think about, or adrenal gland hypofunctioning. Okay, let's think a little bit about our lab values. I don't know what that is saying. Getting a little bit busy here. Okay, let's think about our lab values. Okay, if we know that we have low aldosterone, right, because we have hypofunctioning, what are you going to see? What would be a sign and symptom of a lab? Low sodium and high what? Potassium. Okay. Now, if I have low sodium, do you think I'm going to have a low water intake or a low water volume?
Yes.
Yes. Okay. Tell me what happens when I have low blood volume. What are some signs and symptoms you're going to see? Low blood pressure, right? Did we talk about that with dehydration and low blood volume? How does the body compensate?
High heart rate.
High heart rate. What else goes elevated? Is elevated. Your respiratory rate, right? Try to compensate, get that fluid through. Okay. So does it make sense that we are going to have hyponatremia? We are going to have signs and symptoms of dehydration. What else might we see? The changes in vital signs, but what else might we see? Yeah, but when we come to dehydration, what else might you see besides changes in vital signs when a patient's dehydrated?
Dry skin.
Dry skin, poor perfusion. How would I know the patient has poor perfusion? Pulses. Okay, what are they gonna feel like?
Weak.
Weak. Okay. What else might the patient feel like? You ever been dehydrated? How do you feel? You're happy, right? No,
No.
you feel tired, lethargic. Okay, dry skin, poor skin turgor. Okay, good. Tell me about the bronze skin with Addison's disease. Why would the patient have a bronze, kind of like a glow, like a nice tan, like just came back from the Bahamas for a week, right? What's going on there? Not the liver. What else is increased? What causes us to have changes in our skin color? Melanocytes, right? So those melanocytes are also stimulated. The MSH is stimulated. So a patient may have a bronze kind of glow to them. Okay, that's with Addison's disease. Now there are times when there is other primary causes and they might have vitiligo, right? They kind of have the white patchy. Okay. But Addison's most often has the bronze skin. Okay. All right, we have low cortisol. Okay. Low cortisol is going to cause us to have some hypoglycemia. What about our immune function when it comes to immunosuppressed? Why do we have salt cravings?
So
Because our salt is low,
Salt.
right? Okay, just crave salt. Dysrhythmias. Why do we have dysrhythmias?
it's the potassium.
High potassium. Okay. There's a nice chart in your book that does talk about the adrenal gland assessment, right? Things that you might see for labs, right? So hypofunctioning, low sodium, high potassium. Okay. Cortisol levels obviously are going to be low, right? Our aldosterone and our cortisol is going to be low. So think about treatment. If you're low in a hormone, how do we treat it?
Give the hormone.
Give that replacement. Yeah. Okay. Now, have you noticed that these all end in zone? Prednisone, hydrocortisone. that is gonna tell you that it's a glucocorticoid, it's a steroid, right? So you might not recognize the med, right? But if you know that it ends in a zone, then that medication is a glucocorticoid, okay? And the book talks about cortisone, right? Hydrocortisone. Prednisone is another one, pretty common one. And then fludrocortisone. What kind of medication is the fludrocortisone? The mineral, yep, it's a mineral corticoid, right? So that's gonna help with more of your fluid and electrolyte imbalances. Okay? So if I have a patient who comes in who is dehydrated, how do you treat that patient?
Fluids.
Fluids, okay? I also have a patient who is hypoglycemic and has high potassium. Okay? So how do I know what kind of fluids to give my client? What would be safe to give my client for fluids? Isotonic, such as what? Normal
Normal
saline?
saline.
Yep, normal saline, right? Because I'm low in salt, right? Would that make sense to give 0.9%?
Mhm.
Okay, what else am I low in though? Sugar, yeah. So what can I add to that fluid?
Dextrose.
Yeah, dextrose, right?
D5W.
Okay. So I'm also getting my salt, but I'm also getting dextrose now. Okay. How am I going to treat my high potassium? If you don't know this by now, leave, right? How many times have we talked about this? Logan, I know you know one of them.
That's,
Why do we give them potassium? It's high.
oh, sorry.
But you need to leave, Logan. I'm just
I
kidding.
didn't keep going.
If the potassium is high, how are we going to treat it? Okay, albuterol, quick fix.
Excellent.
Insulin, but wait, if I give insulin, what's gonna happen to my blood sugar?
Gotta go lower.
Could go lower, so careful, so make sure we have some dextrose along with that, right, when we give insulin, what else? It's really high, how are we gonna treat it? What are the other things that we talked about? Calcium gluconate, thank you. So I'll check the heart too. Can we talk about diuretics? Do we need to be careful though? Why do we need to be careful?
Cause they're already dehydrated.
They're already dehydrated, right? Also, we've been monitoring their heart rate.
Mm-hmm.
Yep. Okay. So again, key features, right? They might have some neuromuscular manifestations, fatigue, GI problems, skin changes, cardiovascular changes, right? So all of these are having to do with the low levels of your cortisol and your aldosterone. Okay. What else do we need to check to make sure that we are perfusing? We're giving fluids, that we're giving enough fluids. What are you assessing in your patient when you're giving them fluids? Okay, you can do their weight, good.
Urine.
Lung sounds, okay. What's lung sounds gonna tell me that I'm giving enough fluid? If they're dehydrated, why am I listening to lung sounds?
Make sure there's no crackles.
Okay, so we're giving too much, you're talking about? Okay. If I'm dehydrated, how do I know they're better? What's not diminished? Okay, they might be diminished, but not
Pulses.
necessarily if they're dehydrated. They can still have good lung sounds. Blood pressure,
Heart rate.
heart rate,
Return back to
Pulses?
baseline.
right? What about eyes and nose? Okay, weight, right? You talked about weight, right? We can get a good weight. How do I know I'm giving enough to make them better? And then I should be looking at their labs value, right? Be assessing their labs. Okay. Checking their blood sugar. Okay, what did we say if our patient is hypoglycemic? How are we treating that? Glucagon? What else?
D5.
15 rule.
15 rule, okay, right? Do you think this would help too?
Yes.
Hopefully this would help, right? If they're able to take orally, they can take in sugar. If they're not, we talked about dextrose or we talked about glucagon, right? If they're unconscious. Okay, let's talk about cortisol, right? So we are gonna replace the cortisol that they're missing. Okay? It is important that you give cortisol that it's taken in divided doses. First half is in the morning, right? Second between 4 and 6 p.m. Okay? Never skip a dose of the medication. Why is that so important to teach your client? Never skip a medication or a dose.
It won't have the proper effects.
It won't have the proper effects. Not doing what it's supposed to do, right? And we're gonna go into could go into an acute crisis. Okay? Is it important that they wear a medical alert bracelet? Yep. Okay. Why should they learn to give IM hydrocortisone? If a client has hypofunctioning adrenal glands, right? If they become so low, they go into a crisis. I should have my family member teach me how to do it too, right? So they know how to give their own dose. Okay. Weigh daily. Okay. And this is just an example of cortisol and what happens in the body. Right. So you can see how it peaks right in the morning, right? So we take this is just kind of mimicking the normal balance, right? So if you take the, usually 2/3 of it is given right in the morning and then later on in the afternoon, you would give your other dose, okay? Just to kind of mimic how the body actually releases it. All right, so what is the effect of glucose on cortisol or cortisol on glucose? What do we need to be worried about here?
Regulates metabolism.
Okay, it regulates metabolism, yep, and so when we have a high amount of cortisol,
High
right,
blood sugar.
it's gonna increase our blood glucose, yeah? So high cortisol can actually block the action of insulin, right? It can also increase the amount of blood glucose by releasing that stored glucose that we have in our body. Okay, so let's think about that, how that can be a problem, an issue, when we have a patient who is taking cortisol. Right, if they're taking cortisol daily, could this increase their blood glucose?
Yes.
Okay. Have you ever had a patient, or maybe you will take care of a patient, see this a lot in our COPD patients, right? COPD, they have an exacerbation, worsening of symptoms, they come in, what are they started on? They're started on an IV methylprednisone, okay, which is a glucocorticoid, right? What's that gonna do? Why are they started on that? They have an exacerbation. We're gonna start them on a glucocorticoid. What's that gonna do?
Reduce inflammation.
Reduce inflammation. Yep. Okay. What is also gonna do to their blood glucose level?
Elevated.
It's gonna elevate it. And now we're checking blood sugars. And their blood sugars are in the 200s. And they say to you, I'm not a diabetic. I've never had to check my blood glucose before. And now they're getting insulin. Right? It's the effect of that cortisol, that glucocorticoid that we're giving them. Okay. Does that mean it's going to be long-term?
No.
Hopefully not, right? But they might have to take prednisone long-term, but they may also have to check their glucose levels. But just be aware that maybe that's why you're checking. They're not a known diabetic, but now they're taking an IV glucocorticoid and you need to check that. Okay. All right, let's go back to the acute adrenal insufficiency. Okay. Right, so we talked about a client who has Addison's, right? Can that be managed? Addison's. What do we have to do? Teach the patient to do what? Take their medication, right? Take their medication as scheduled. Right? Increase their cortisol, increase the aldosterone. Okay. There are times though when a patient can have what we call an acute adrenal insufficiency or Addisonian crisis. Okay, so this is a crisis. This is a medical emergency. Okay. The need for cortisol and aldosterone is greater than what's available. Occurs when there is a stressful event. Tell me about a stressful event a patient might have in their life where they might have to increase cortisol needs.
One example.
Child one exam, absolutely.
Death
You
of
should
a loved
always take
one.
An extra dose of your glucocorticoids before you come.
Death of a loved one.
Surgery.
Okay, surgery. Any type of trauma, any type of infection, right, on the body is gonna cause an increased need. Okay, if that patient doesn't have enough, they can go into a crisis. Okay, so what's gonna happen in the crisis that we have to really worry about? Severe hypotension, their blood pressure is gonna be like 70/20. What are you gonna do about that?
Mhm.
You just gonna stand there? What are you gonna do?
No, fluids.
You're giving fluids, right? They're not perfusing. What's gonna be super high?
Heart rate.
Heart rate and also what? Potassium. Okay? They're gonna come in a crisis. They're gonna have low blood pressure, high potassium. So very severe medical emergency. Their sodium level is also gonna be low, right? What did we say about a low low sodium level? What do we need to be worried about?
Seizure, coma, death.
Seizure, coma, death, right? Remember that? Okay, so we need to monitor that. Okay. So patient comes in, severe hypotension, we're gonna give fluids, right? We are lacking hormones, so how are we gonna give these hormones?
Alright.
IV, right? Okay. So on page 13-14 in the newer edition, it talks about how are we gonna treat a patient who is in adrenal insufficiency, acute adrenal insufficiency. Okay, we're gonna give them fluids to get that blood pressure up. Okay, we're gonna give them the IV glucocorticoids, right? Hydrocortisone, dexamethasone, those are all your glucocorticoids. Okay. We also need to monitor their blood sugar, right? That's also gonna be low. Okay. We talked about how to do that. And then we also need to treat our high potassium. Okay,
I have a question.
yes.
So is this the one, or am I thinking of one of the different ones coming up? Where like the norepi and epi aren't gonna work? Or is that a different one?
I'm not sure.
Okay, I'll just look it up.
Okay, I'm not sure. As a treatment, you're saying?
To help blood pressure, yeah.
Oh.
There's one of the endocrine
Yeah.
ones that if they're gonna be refractory to.
I remember talking,
But
I
I
remember
don't
reading
remember
about
off the
that
top of my
one,
head.
and I honestly can't remember which one that one is either. Yeah. Thank you for reading and knowing that. Okay, hyperkalemia. What did we say? How are you gonna treat it? Go.
Insulin, but watch the blood sugar.
Put them on telemetry.
Okay, diuretics. Should I give spironolactone?
Mm-mm.
It's potassium sparing. Gonna kill your patient, right? Okay, could I give a thiazide? Could I give
Yes.
hydrochlorothiazide?
Yes.
Could I give a furosemide?
Yes.
Okay, but also, what are we monitoring? Got a lot going on here, right? We're monitoring blood pressure, blood sugar, I's and O's, right? All of that needs to be monitored. Okay? Got it? Question? Okay, let's talk about the opposite kind of, right? Let's talk about Cushing. This is kind of the opposite of Addison's. Okay. Adrenal gland hyperfunctioning, so Cushing syndrome, Cushing disease. Okay, so now we have an oversecretion of our adrenal cortex, which is making excessive amounts of your cortisol, aldosterone, androgen production. Okay. So what do we need to be concerned about here? We have an overabundance. Overabundance here. And again, causes can be due to the adrenal glands. Or it could be something outside, which a lot of the times with Cushing's disease, it can be caused by taking oral prednisone, IV prednisone, right? Taking endogenous cortisol replacement. Okay. So things that you're gonna see, you're gonna see some skin changes, right? We've got changes in fat distribution. We have changes in our glucose, our immune changes. Psychosocial, it does change our emotions. High cortisol, right? Cause you to be laughing 1 minute, crying the next minute, right? What do you think is gonna happen to our cortisol levels in our blood, saliva, urine? Those gonna be elevated or decreased? Elevated, yeah. Okay. And then looking at the brain or the adrenal gland, right, to see what's causing it. Does it have to do with maybe a tumor on the pituitary gland? Or does it have to do with something with the adrenal glands? Is it a tumor on the adrenal glands? So again, free cortisol, it could be caused by long-term or prolonged steroid therapy. Usually when we say disease, we talk about Cushing's disease, it has to do with some problem with the pituitary or the adrenal glands not talking. When we talk about syndrome, usually that means it has to do with taking a replacement steroid. Okay. If a patient is taking a replacement steroid, they may have some changes, some body changes. And once those are stopped, some of those kind of changes to the body can be reversed. Okay, but again, you never want to stop taking your hydrocortisone, your prednisone, just all of a sudden stop it. Okay, okay, going to cause that patient to go into acute adrenal insufficiency. Okay, so these are some characteristics we might see. Changes in the fat distribution. They might have a moon face, buffalo hump with extra kind of fat between the shoulder blades there. Okay, thin limbs. Okay, more of a truncal obesity. Okay. If we have increased aldosterone, what are we holding on to? Sodium and water. Is that going to cause a weight gain? Okay. We have some striae. We're going to have decreased lymphocytes. So what happens to our immune function then? Yeah, we're at risk, right? Risk for infections. Emotional instability, like I said. So my patient might have mood swings. Weight gain. If you've ever known anybody who's maybe been on short-term prednisone, have they ever said anything about their appetite? Hungry, yeah, increases the appetite. Okay. The moon face, right? The face can become very kind of round. If I'm holding on to extra water, we talk about weight gain, but what else can happen? Potassium is high or low? Low, okay? Our sodium is high or low? Okay, if I have high sodium waters following, what happens to my blood pressure? Goes up, right? Yeah, it goes up because I have all this extra fluid. What happens to my glucose levels? What? All right, so we're gonna measure cortisol levels, right? Those are gonna be elevated. Like I said, for diagnostic, they'll look to see, is it something to do with pituitary? Does it have something to do with adrenal glands? Patients also at risk for osteoporosis. Okay. Calcium levels can become low. We have low calcium levels. The bones are kind of being broken down and the kidneys are kind of flushing out all of that calcium. So we have low calcium in that patients at risk for bones, for osteoporosis, for fractures. Okay. All right. So let's look at some of the priority problems when it comes to a client who has Cushing's. Okay. So fluid overload, right? We said if we have more aldosterone, we're holding on to sodium and water. Okay? What did we learn about a client who is fluid overloaded and some treatment that we can do?
Diuretics.
Okay, we could do some diuretics. But we need to be careful too with diuretics, because what can we get rid of?
Potassium.
Potassium. Is our potassium high or low?
Low.
It's low. Okay, so just be careful, right? When we're getting rid of that, we have to monitor that.
Sterling.
Okay. Yeah, spironolactone, would that be a medication we could give? Absolutely. Okay, what else should we do if we're fluid overloaded and we have too much fluid? What's another intervention? Fluid restriction. Yeah, good, absolutely. Restrict fluids, but also might need to restrict what in our diet? Salt, right? Your sodium. Okay. All right, what else? What else would we monitor for fluid overload?
Daily weights.
Daily weights are good. Edema, okay, so we could do for edema. Also watch for pulmonary edema, right? So we got fluid overload, we talked about watching, listen to our lung sounds, watching for that, that can occur. Putting crackles, shortness of breath. Yep, jugular vein distension, good. Watch for skin breakdown, because that can occur too with our fluid overload. Right, so what do you do for skin? What are you monitoring? What are you doing for watching for skin breakdown?
We repose.
Reposition. What else? Where are you assessing for skin breakdown? Pressure areas, right? Heels, elbows, if they're wearing oxygen, right behind the ears. anything that's on
Coccyx.
contact. Go ahead.
The coccyx.
Coccyx, yep, that's a big one too. Yep. Okay, good. Okay. There are some medications that the book talked about. You are not going to be responsible for those, right? But there are some medications that can interfere with the ACTH production. You're not gonna have to know those medications for this class, but just know that there are some medications the patient may be given. Okay. What about potential for injury? Why is the client at risk for injury? Okay, low calcium. Yeah, easily bruised, low calcium, which could lead to bone fractures, osteoporosis. Okay. So how would you handle your patient? How would you transfer your patient? Gate belt, okay, so they don't fall. The book talked about what? Lift sheet versus, just yanking on their arm and pulling them out of bed. Maybe position them that way. The lift sheet would help. Diet do you think this client would need to be on? High calcium, vitamin D, what else should you be putting on? Protein would be a good one. High protein, low sodium. What's my glucose level?
Hi.
High, okay, so think about your carb intake also, right? Okay. And then the client is also at risk for infection. Okay, so if you have a client who is at risk for infection, Hannah, what's something that you do? You wash your hands. Biggest thing you can do, right? Wash your hands. Okay, Kylie, anything else you would do for potential for infection? Okay, what kind of precautions if they're at risk? Okay, so they would be on what? Protective, right?
Mhm.
Are they infectious?
No.
No, we might be though, right? So we would wear a mask. Wash our hands. What else would we do with equipment or anything?
Keep it in their own.
Hand, right? Make sure you clean it really good. Then what else would you be doing or assessing if a client's at risk for infection? Temperature, okay, so looking at vital signs. Okay, what else?
Labs.
Yeah, like what labs? Blood health, yep, white blood cell count, is that elevated? Okay. Where might they have an infection? Where might you be looking?
Wounds.
Okay, wounds would be a big one. Where else? Where else do patients have infections? UTIs, okay, so looking at that urine, does it look cloudy? No. Okay. Respiratory, right, any cough, fever, changes in lungs. Okay, good. So treatment, right? We talked about there might be some medications that we can be given, but there are also some surgical treatments that can be done. Okay, so we have either adrenalectomy, so removing the adrenal glands if that's where the problem is, or removal of a pituitary tumor. If it's a pituitary issue, we might have to remove some or all of the pituitary. Okay. So what is that called when a client has pituitary removal? What is that surgery called? Transfenoidal? Yep. Transfenoidal what? Hypophycectomy, right? So we're going in kind of nasally here or through the sinus cavities to kind of clip out that pituitary gland. Okay. So tell me about that. Think about if a patient had that surgery and you are taking care of them post-operatively, what do you need to be watching for? Okay, bleeding?
Don't blow your nose.
Don't blow your nose. Okay, why do we not want to blow our nose? Okay, it's sensitive. Okay, we could have a blood clot, or we're blowing. What else happens when you blow?
Pressure.
Yep, ICP, so pressure, yeah, good. What else do you do? Okay, how do you monitor for cerebrospinal fluid? Often they have like a mustache dressing, right, that kind of goes right below their nose. What would you monitor on that dressing?
Drainage.
Yeah, that drains. What does it look like if they have CSF? Yeah, that yellowish kind of tinge halo. Yep, good. What else? What
Keep
else
the-
would you assess or check for? Yeah, neurological is very important, because what could happen? Anything. How would you notice? When you say you assess neurological, what are you assessing?
Orientation.
Orientation, okay? What else? Pupillary response? Are they alert? Are they lethargic? Is there a change in level of consciousness? Okay, good. What else? Anything else you would assess? Check for? Okay. Pulses, yeah, so you do your kind of full body assessment. Elevate the head of the bed, avoid coughing, bending. What does that do? Yes, that will increase our ACP. We do not want to increase our ACP. Okay. Meningitis, right? Think about that. We have a direct entry into the brain, right? Are we at risk for infection there of meningitis?
Yes.
Yeah, what might you notice the patient, says, complains of, noticing changes? It has a neck pain, headache is a big one. Yeah, fever, yeah, good. Avoid straining, right? That's also gonna decrease our ICP. Why might we have to give vasopressin or desmopressin? Why might we have to replace that?
Is it that the removal of the tumor could somehow affect the adrenal gland
Not the adrenal
or
gland.
the,
Yeah, pituitary, right? If we're removing the pituitary, it might not be secreting. Right? If we remove the whole thing, is it gonna be secreting those hormones that it's supposed to? Okay, yep, so patient could be at risk for DI. What did we say DI was? Diabetes insipidus. Not enough what? Which hormone? ADH, antidiuretic hormone. Does desmopressin replace that?
Yes.
Good. All right. Questions on that? Okay. Without looking at your book, using that wonderful tool you have in your head called your brain, okay? Jot down a few things that we just talked about when it comes to Cushing's versus Addison. What are you looking for? What's happening? Are there changes in the lab? Use your brain.
Thank you.
Your brain, I know it's gonna work. I know it's Monday. Bring it in. Okay, just jot down a few things. Don't look at your book, don't look at your notes. What did you just retain from that? Somebody written down, right? All right, Brittany, what's something that you wrote down for Cushing's? One thing. Fluid overload. Okay, good. Shayla,
I put Buffalo Hump mood swings. Great name.
good. Okay, good. Kayla,
Decrease potassium.
decrease potassium. Okay, good.
Sodium.
And increase sodium. Good. Logan,
I had,
anything else you want to add?
I just had increased fluid retention.
Okay, fluid retention. Okay, fluid overload. Okay, Mary, decrease potassium. Anything else you had in there that we haven't talked about? Okay, is it elevated?
Oh, no.
No,
Well,
it's low. Yep, so low calcium. Okay, good. Mackenzie, anything else? Too many steroids, right? Yeah, yeah. So syndrome could be taking too much of your prednisone. Kelsey, should I pick any today? No. No, okay. She wasn't listening. Courtney, anything else?
I was so frustrated.
Still in Cushing's. What is our treatment?
Possible remover of pituitary
Okay,
tumor.
so we can remove the pituitary, the hypophyseectomy, or transfenoidal, that's a transfenoidal hypophyseectomy or adrenal gland removal, right? Those could be treatments. Along with, there are some medications that block ACTH. What happens if a patient's just taking steroids for an allergic reaction, a severe allergic reaction? Yeah, taper them off, right? And so the symptoms hopefully would get better.
Also high blood sugar.
High blood sugar, yep, hyperglycemia. Yep, hyperglycemia. Mhm, yep. Okay, all right, anything else? With Cushing.
Women facial hair?
Okay, women might have some changes with facial hair, yeah, so the increase amount of the androgens might have some changes there. How about our immune function?
Weekend,
Yep, weakened, good. How about our emotional stability?
all over the.
All over the place, absolutely. All right, how about Addison's disease then? Taylor,
Too little cortisol.
too little cortisol. Okay? Austin,
Got the bronze hyperpigmentation.
hyperpigmentation with that primary autoimmune disorder, yeah. Kira, yes, sodium's low, potassium is high. Good, Hannah, immunosuppressed. Okay. Kylie?
Low blood pressure and pulse.
Yeah, low blood pressure, right? So that's definitely something we need to worry about, right? Hypotension, right? So our sodium is low. Potassium is high.
Alright.
Our cortisol level, low. Our calcium, high. Our blood glucose,
Low.
low. Okay, 9, if a patient goes into an acute adrenal insufficiency or crisis,
Mhm.
how are you gonna treat it? What's one intervention?
IV corticosteroids.
Yeah, IV glucocorticosteroids, right? We're gonna replace those steroids the patient is missing. Alyssa, what else can we do if a patient is in an acute adrenal insufficiency? We're gonna give them steroid replacement. What else? Fluids, yes, we need to get fluids because they're severely hypotensive. What kind of fluids are we gonna get? Isotonics? Yep. Or we can add some D5, right? Okay. If it's so low, how else can we replace that sodium? What's another way that we can replace the sodium? What other type of fluid? Hyper, what, 3%? Remember we talked about 3% sodium chloride? Okay, so we're gonna replace the steroids, we're gonna reduce fluids, what else are we gonna do, Amanda? What else we need to be worried about? An acute adrenal insufficiency. The blood pressure is really low. Yep, what's really high that we also need to take care of? Potassium, yeah, how are we gonna take care of that high potassium? Yep, calcium gluconate. Tiffany, how else are we gonna help decrease that potassium? Insulin, diuretics, yep, very good. We got this, all right? So you need to understand what hormones are involved. You need to understand what's gonna happen to my labs. And then you have to think about what interventions have. Calcium regulation. We'll talk about PTH. Parathyroid hormone. All right, so we have your calcium regulation, right? So when we're talking about calcium, we're talking about parathyroid hormone and calcitonin. Okay? So the parathyroid is going to secrete your parathyroid hormone. So it's gonna help regulate your calcium, regulate your phosphorus levels, right? With the help of the bones, the kidneys, and the intestines, right? Okay. So another picture, right? When our calcium levels become too low, the parathyroid hormone is gonna release. Okay, it's gonna take some of that calcium from the bones, it's gonna increase it from the intestines, and increase uptake from the kidneys to make it normal, right? Because we want our calcium level to be normal, homeostasis. Okay, and on the opposite end, right, when calcium levels are increasing, okay, then calcitonin will be released from the thyroid gland, right? And it stimulates a release from the bones, reduces calcium uptake, so we get rid of that extra calcium to normalize. Okay, so the parathyroid and the parathyroid hormone and the calcitonin kind of work together. right? With the help of the kidneys, the bones, and the intestines. Okay, so remember the parathyroid glands are kind of embedded in the thyroid. Remember how we talked about the client has thyroid removal? Could they also have signs and symptoms of low calcium because of the parathyroid also being removed? So calcium, phosphorus, right? So when we have a low parathyroid hormone release, our calcium is gonna be low. When we have a high parathyroid hormone release, our calcium is gonna be high. What is our relationship between calcium and phosphorus? Opposite, okay? So if I have low parathyroid hormone being released, my calcium is low and my phosphorus is high, okay? If I have high parathyroid hormone, too much being released, calcium is high. And then watch for your low phosphorus. All right, so just real quickly, I mean, these are pretty rare. We don't tend to see them as maybe as common as in other of your endocrine disorders. But hypoparathyroidism, okay? Again, a decreased function of the parathyroid gland. Okay, so it could be due to surgery, okay, or some type of damage to that parathyroid. So we have decreased calcium, okay, increased phosphorus we need to watch for. These glands also have low magnesium. Okay. This low magnesium can actually suppress parathyroid hormone release, right? So if you already have low magnesium, it's going to cause less parathyroid from being released, parathyroid hormones from being released. So your calcium levels are going to be low. So think about a client who has a low calcium level. What were some of those signs and symptoms that you can think of that we've learned about?
Schwarz.
Schwab checks, those are positive, good, what else? Tetany, cramps, numbness, tingling in the hands, the feet. Can have some heart arrhythmias. Okay. So if we have low calcium, how are we going to treat it? Giving calcium, good. Okay, so calcium gluconate. Do you think we're also low in vitamin D? Okay,
Yes.
so replacing that vitamin D. Calcitriol. Calcium carbonate, right? Think about Tums. Taking Tums, you're taking calcium. Okay. If our magnesium is low,
Give magnesium.
give magnesium. Can we give that oral or IV? Yeah. Some clients actually can get parathyroid hormone injections also. Okay, because that's low. Okay. What about our diet? Yeah. So make sure though that when you're increasing your calcium, right, that it's moderate, right? So make sure that we don't want our phosphorus to go higher too, right? Because all of our foods that are high in calcium are also high in phosphorus. Okay, so green leafies are good, right? Broccoli, breakfast cereals that are fortified, those have good calcium in it. Your milk, your dairy, is that good calcium?
Yeah.
But it's also got phosphorus in it?
Mhm.
Okay, so gotta be careful there. All right. The opposite then is hyperparathyroidism, right? So increased parathyroid hormone is being released. So what happens to our calcium? It's up. That hypercalcemia, and our phosphorus is
Low.
low. Okay. So again, this can happen in a parathyroid tumor. It can happen any neck trauma, right? Chronic kidney disease. So these clients can have kidney stones. This extra calcium can actually be deposited into the soft tissues. Nausea, vomiting, weight loss can happen because of the high calcium. Psychosis can happen. Bone pain. Okay, bone cysts can form. So we have high calcium, we have low phosphorus. Parathyroid hormone is elevated. And our magnesium is usually also elevated. So what are some ways do you think we could get rid of that extra calcium in the body? Diuretics, yeah, that's a good one, right? Diuretics. Okay, get rid of the extra calcium. Is there one type of diuretic that we should be not giving? Yeah, thiazides. Remember, your thiazides are gonna hold on to calcium. Could we give loop? Could we give calcium spirit?
Yes.
Yeah, just be careful with your thiazides. There's a medication called Cincaloset, and that helps to bind calcium and get rid of the body, get rid of it in the body.
How do you spell that?
Cincalcet. Cincaloset.
Sure.
Could be increased phosphates. Does that help?
Yes.
For low? Helps the heart, right?
So I'm sorry, I might have missed it. Where does calcitonin play into this or?
Cinacalcet, it's a binder. It binds to calcium.
Okay.
It binds to it. And bisphosphonates is another medication that's given for these clients. Have you heard of bisphosphonates?
Mm-hmm.
Yes. Yes. The endodronate. Right, so you ever see medication that ends in dronate, it's a bisphosphonate. It helps to push that calcium or back into the bones and prevents bone loss. So a lot of times we'll use this for osteoporosis. Okay, bisphosphonate, what is that one? Alendronate? Alendronate? Okay. Anybody know what precautions you have to take if you give a bisphosphonate to a client?
About 30 minutes.
Yep, they have to stay upright after taking it because it can cause esophagitis. How else do you take it?
In the morning.
In the morning on
Empty stomach.
empty stomach, and what do you take with it? Glass of water, just plain old water. Okay, plain old water. That would be another medication that could be given, to help keep that calcium back into the bone. Hydration is also important here. We want to give IV fluids, right? IV fluids will help flush out that extra calcium.
So
Prevent any kidney stones that can occur.
so you're giving diuretics, but you're also giving fluids.
Because you want to get rid of the
You wanna
extra
get rid of
calcium,
the
but you don't want them dehydrated.
Dehydrated, yeah.
That helps push all that extra. All right, good job. So just that briefly on parathyroid. Okay, so why don't we take a break? It is 10 after 10. Let's come back at 10. The last slides here. And talk about maybe. Gonna work. The newborn screening then.
92.
So if you work in pediatrics, OB, clinical, peds clinical, you may interact with this newborn screening, okay? And it's just what it says it is, right? This is blood work that is done on a newborn, usually within the first 48 hours, to detect any treatable serious medical conditions, okay? Currently, the Wisconsin Department of Health screens 48, it should be 48 now, they added with this Pompeii one not too long ago. So there's 48 different types of either congenital or metabolic disorders that can occur, okay? So newborn screening is usually done within the first 48 hours, sometimes they'll do at least the first week of life, Okay, it is like a wall, like it needs to be done, like, when I was looking at it, it says that it can be, patients who have religious beliefs may not have to have it done, but most newborns will have this.
What if it's a home birth?
Well, they should still be seeing a practitioner for follow-up, so they can do like a follow-up appointment, yeah. Yep, I've seen it done in the hospital, or I've seen it done at their 3-day well check, when they come in, yeah, so, it should be done, they can say no. But it does, like I said, it screens for 48 different types of disorders, okay? Some of these that we'll talk about, the metabolic ones, like PTU, galactosemia, it checks for, cystic fibrosis, hypothyroidism, sickle cell, okay? So those are done, hopefully to prevent, or not prevent them, but treat them, right? If we know that they have a different metabolic disorder or other disorder, treat it, know it early enough that they can cause any long-term complications, okay? All right, so some of these that are included in the newborn screening, so I'm gonna go back here, sorry. So when we talk about inborn errors of metabolism, they're pretty rare, okay? There are some genetic disorders though that we're gonna talk about, right? I'm just gonna talk about a few of these. As you're looking through the book, there's a variety of different ones, but I'm just gonna focus on a few of these, okay, for this class period. So most, again, are detected in a screening test. Okay, they can be done in utero, or it can be done in your newborn screening. And a lot of the signs and symptoms for these newborns, these babies, is gonna be lethargy, poor feeding, right? If they're not feeding, they're not eating, they're not growing, right? So they have a failure to thrive. They may be vomiting, okay? Those might all be signs of an inborn error of metabolism, okay? So two that I want to talk about here are galactosemia and maple syrup urine disease, okay? So galactosemia is that the child cannot break down galactose to glucose. So it's a disorder where they cannot break down galactose. They're deficient in an enzyme. If the client doesn't realize they have it, or they continue to take glucose like that, they can have liver problems. They can have intellectual disabilities. Because these byproducts can cause kidney problems, liver problems. So the treatment is just to avoid dairy products. So this child would have to, as a newborn, stick with like a soy-based formula. And then as they get older, they'll have to have a lactose-free diet. So they want to avoid dairy products, but they can still enjoy like fruits and vegetables and proteins. If they're not taking in any dairy products, they also will have a calcium supplement that they'll have to take. Maple syrup urine disease, kind of an interesting one, right?
Sounds fake.
That sounds fake. A deficiency in the enzymes, or the amino acids, they can't break down valine, leucine, and isoleucine. Okay, so those are some amino acids. So they're missing a component there that breaks down those amino acids. So then they accumulate. Okay, and what's interesting is that the child's urine, their sweat, even their earwax starts to smell like maple syrup. So kind of that sweet maple smelling. If not treated, the child can have brain damage, intellectual disabilities. They can develop seizures, tremors. This tends to happen in maybe some of your closely related parents, like Mennonites, Amish might have this disease process. So protein restricted diet. So it doesn't mean you have to eliminate the protein, but you have to restrict it, right? So think about what are some things that you probably need to limit when it comes to, your meat products, dairy. Okay, they have some protein.
What's the difference between like the galactosemia and like just a regular lactose intolerance?
I don't know if it's just the enzyme, if they're missing a certain enzyme. Depending on how it breaks it down. Yeah. Same kind of thing though, right? Lactose, you want to avoid that, anything that has lactose in it. All right, and this is just an example of like a protein powder. Okay, so getting some protein through the powder, right, but doesn't have those, leucine, isoleucine, valine, those amino acids that the body can't break down. So the child could be on a protein powder to help get to that extra protein too. Another one is PKU, phenylketonuria. They kind of changed the name a little bit now. So you can either see it as PKU or sometimes, oops, they'll call it, in your book, it was talking about phenylalanine hydroxylase deficiency. I feel like PKU is so much easier than saying that, right? Phenylalanine hydroxylate deficiency, or also known as PKU, okay? They are deficient in an enzyme that helps to break down phenylalanine to tyrosine. Okay, so it's just, again, they're missing an enzyme. So then these toxic levels start to build up in the blood. Patient can have vomiting, they can develop some seizures. They also say like a musty odor to their sweat, to their breath. The body cannot metabolize that phenylalanine, okay? So like again, becomes very high levels. So what do they need to do is they'll need to be on, low calorie phenylalanine. This would be an example of a drink mix that they would have to be on. Okay, again, getting some protein. They again need to avoid anything with high protein. So your milk, your meats, your eggs, cheeses, nuts, legumes, like those can be all high in protein. So they need to restrict those.
A very restricted diet.
Yeah, very restricted diet. Fruits, veggies, starches, those are okay. Fats, honey, sugar. Another thing that's very important with these clients is they have to avoid aspartame. What is aspartame?
A sweetener.
Yeah, sweetener, like artificial sweetener, like a Sweet and Low or Equal, right? A lot of your diet sodas will have aspartame in them. And so they need to avoid the aspartame also.
That's like.
Like Splenda, yeah, like a Splenda, Sweet and Low, Equal, were the names for them.
Stevia would be okay though, right? Because.
That's a natural sugar, isn't it?
Yeah, stevia is.
Yeah, sugar, yeah, natural sugar is okay. Sugar, honey, like that is okay, but not anything that has the aspartame in it. Yeah. Okay. So low protein, this would be a way to supplement protein. And the last one I want to talk about is Tay-Sachs disease. Okay, again, a very rare, these are all pretty rare, but they do happen. An inherited disorder that actually affects and destroys the nerve cells in the brain and in the spinal cord. So what happens is these clients have a deficiency in hexosaminidase.
That word.
An enzyme that helps to break down the metabolism of fats. Okay, so what happens is these deposits then they can't be broken down. They deposit on the nerve cells of the brain and the spinal cord. Okay, and over time, the patient can have physical and mental deterioration. Is often found and can be checked in the Ashkenazi Jewish population. And again, this is a progressive disorder. Okay, it's a neurodegenerative progressive disorder, so they don't get any better. What happens is that infants start to develop, they develop normal, right? Normal for about 5 to 6 months. So they're meeting all their milestones up until about 6 months of age. Okay, so think about, what is a baby doing up until about 6 months of age?
Cooing.
Cooing,
Lifting its
they're
head.
lifting its head, doing some rolling over. You know, some babies are sitting about 6 months, depends on every child. Does every child progress the same?
No.
No, right? Some children might be sitting up with assistance or by themselves by 6 months, some don't. Okay, but what they notice is that physical development begins to slow, right? Then they're not meeting those milestones, right? They're not sitting by themselves at 9 months. They're not walking by a year of 15 months. Okay, so they start to have deterioration of that. Okay. Over time, they can have blindness. They can develop hearing and vision loss. They start to lose muscle mass, muscle weakness, so they're regressing, right? They're not progressing into the different stages, they're actually regressing, okay? And death usually occurs between about 2 to 4 years of age, and it has to do with respiratory, like a pneumonia, because of the muscle weakness. Okay. So treatment is really palliative, right? When you're thinking about this child who maybe is regressing, what are some services do you think you could offer to the child and the family? What services might help that child? Quality of life. What do you think? If they have some problems with muscle weakness, we could get involved.
Physical therapy.
Physical therapy. Okay? If they're having some problems with swallowing, who could get involved?
Speech.
Speech, right? Speech and language. Occupational therapy. Respiratory therapy. Respite. What's respite?
They take the kid to the parent.
Yeah, right, so we can have, give that kid a break, because they're gonna probably need 24/7 care, okay? What about hospice care? Would that be something also?
Yes.
Okay. What about services for the family?
Possibly
Parents.
chaplain.
What's that?
Chaplain.
Chaplain? Counseling?
Support.
Support groups? Yep, those would all be really good ones too. So again, it's a progressive disorder. There's no treatment for it. It's just supporting the child and supporting the family. All right. All right, fun activities.